Can I get a confirmation from someone that you're seeing the slide only and not the notes? Because I haven't.
Yes.
Okay.
Slide.
Amazing. Thank you, Anne. All right. So, I mean, we're a small group. I know this is recorded, so we'll make it so that someone can follow. But if you want to put on your camera or if you have questions, I will make an effort to monitor the chat at the same time. It will be more informal since we're a small group. So I really invite you to ask questions and just intervene whenever, if ever you have specific questions. So as David was introducing, and I want to thank David for reaching out to our organization. We are based in Montreal, but we're a pan-Canadian organization as you see it by our name. And I hope you'll be able to kind of familiarize yourself with our work and why we think this is so important. Although if you're here today, you may already be convinced that it is. And part of our work really is raising awareness, and really more than raising awareness, actually equipping and providing tips and actual concrete examples of how you can make changes in your own life or the lives of people you care for to make sure that they are, if not, you can prevent, or if they're happening, you can flag medication side effects or harmful effects, if we call them here, of medication, so that you can really be proactive in that matter. So yes, the title of our talk today will be Medications as We Age. Oh, I think, yeah, today is really not a great technical day. I see my PowerPoint just crashed. All right, so I'll just keep going anyways while it's rebooting. So the aim of this presentation really is to talk about specific medications, yes, that we are concerned about, but also, so when we look at medications, there's an aspect of quantity, but also of quality. So when people come to me and say, I'm only on one med, I just stop them and say, you know what? I've seen people on 8 medications and they needed each and every one of them. But I've seen people on one, and that one was superfluous or just not needed or perhaps inappropriate. So yes, number is an information, but it isn't all of the information for sure. So just wanted to raise that point. We're going to be talking firstly about the phenomenon behind it. So the context, I think, is important. So going over what we call polypharmacy, I'll be defining that and where we're at in Canada with that, which isn't great. To be frank, we are seeing this phenomenon ramping up in terms of the number of meds people are on, and also the proportion of inappropriate meds that are being used on a day-to-day. It's constantly increasing. So quite concerning. Hence why we need to raise awareness among the public, but also among health professionals. So we're doing this work on both fronts. Let's just say it that way. And afterwards, we're going to go really into identifying specific meds that could be of concern. And finally, we'll be providing, strategies that you can apply on a day-to-day to prevent medication harm. And then the PowerPoint should be back up. Are you guys seeing it?
Yes.
Sorry about that. So hopefully it doesn't crash again. So our plan for today is, just pretty much what I was saying. So identifying the potentially risky situations, then what we can do as a caregiver or a patient, and then why we're so concerned about this. In terms of conflicts, I do want to mention our organization is funded by research funds. So we do this really from perspective that what we're raising awareness, and we're measuring over time how awareness is increasing or changing, hopefully increasing, but changing in the general population. The information I'm providing today, you can use it, you can just not use it. For me, there's no difference in terms of the money I'll make in the end or not. Really, it's so no conflict to declare. So really, to dive into the topic, just to start off, we always like to remind people, and I just joke around and say, I mean, I didn't become a pharmacist because that's what I am first and foremost, to go out and say meds are bad. Okay, so meds are good in many ways. And if I was to really simplify, we have David here who's a chemist. He probably can think of so many ways medications can impact our body and our health. But if we're really going to go down to a simplified way of indicating why people take meds today in Canada, we usually regroup them under two, to simplify it really, we're going to look at chronic conditions. So really that's about controlling a condition that won't go away, right? By nature, it is chronic, and preventing it from degrading or really complexifying itself. We can think about diabetes. An individual may be diagnosed with diabetes, and if we're able to control their blood sugars, if we're able to control their blood pressure and look at a bunch of different risk factors with medications, we can prevent a number of things, including eyesight issues, problem with limbs. We've seen wounds that don't heal, for example, and problems that are like heart attacks or strokes. So by managing the diabetes, we prevent further degradation of the health. And there's a number of chronic conditions. I'd say today in Canada, that's why most people take meds. It's because they have a chronic condition. They have a chronic condition or multiple ones, often a lot of them, more than one. And the other reason why people take meds is really to improve symptoms, just kind of putting them in a different category. That can be just knee pain, headache, etc. Just to say that a lot of it is about quality of life when we're looking at symptoms. Meaning, I can take a Tylenol, to whatever name, any medication, because I have a headache now, and then I'll be able to, make this presentation and go on with my day, versus not taking it. Well, I won't live longer because I took that medication for sure, but it will help me function. With advance in age, usually people see much more a broader importance or bigger importance in terms of symptom management than the actual prevention of further events, etc. So we're really looking further, really strongly at quality of life as we advance in age. So we're seeing that as well increase the use of medications for symptom management. And that's one of our roles as an organization, is also to remind individuals that medications are not usually the only way to respond to symptoms. So, and we can look at different approaches if there are evidence-based and if they work. We'll touch this briefly today. And prolonging life expectancy is certainly a huge benefit of medications. And one of the reasons why today, although I do think I've read that life expectancy did go down recently, unfortunately, because of COVID slightly, but medications are behind why we live longer than ever in Canada, or more so in the past few years. So medications are good in many ways. And the last thing I want you to do is to go home and just kind of, or you're already home, so just to kind of move away from this presentation and just think meds are bad. So don't stop all your meds after my talk. So meds are beneficial in many, many different ways. So why are we so preoccupied by them? I guess what I need to start off by doing is just describing or just showing quickly a portrait of where we're at in Canada. These numbers are dated back 2016, if I remember well. Their stats in terms of Canadian seniors. Seniors are considered, in terms of the public medication plans, we're looking at 65 years and above. So we're looking at individuals that live at home or not in long-term care setting and who are 65 and above. And I'm going to ask you to just think about what you see in your entourage or around you in terms of the proportion of individuals in that category. So living at home, older than 65, who take at least 5 prescriptions. So just think about it. I guess what I need to remind people here is that this does not include over-the-counter meds. So I'll let you think a little bit about it. The answer is 66%. So we have 2/3 of seniors in Canada who live at home who take at least 5 meds. Okay, This should start. We're looking at the same group again, so community dwelling older adults, but this time around we're looking at 10 or more prescription meds. So the stats here are about 1 in 4. So 27% of older adults take at least 10 prescription meds. And last question I'm going to ask for this short introductive quiz really isn't that much about proportion or numbers. I just want you to think more so about the effect of age on the number of medications we take, even among the subgroup of seniors. So when we're looking at this, the population aged over 85 this time around, so 20 years older, what proportion of them take at least 10 or more medication? Would you think it's more than the group including the 65 and above, or less? So you can look at it through 2 lenses. You can consider that perhaps they're older than the average Canadian life expectancy, so they're healthier, taking less medications, but in fact it's more. So the older we get and the more medication we will have in our pharmacy cupboard or in our blister pack, really. So this is about 2 in 5. So really, a lot of seniors taking a lot of medications is probably the way I summarize this slide. But I mean, I always like to pause, and usually I present to groups that are super active and in their community. And I guess I don't need to really make this point because they are themselves a representative of this exact philosophy. But older adults contribute so much to this, to society, and they are not a sick population. It's not the portrait I want to paint at all, and it's not what we are. Our message isn't about that at all. And a lot of them, I mean, report being in, more than half of them report being in very good health. So really the point here is it's a spectrum. People take, some seniors take no meds, some take a lot, but it's really about just showing the trend. And over time, we've seen numbers creep up in this population, but also in other age groups as well, in younger populations. So why are we so concerned, though, about seniors taking medications and taking more of them? So there are reasons for that, biologically, physiologically, that actually make us more preoccupied for this population. So as I mentioned before, just to reiterate, we take more meds as we grow older, not necessarily because we can have more chronic conditions as we age, but also because a same chronic condition can evolve, and then we can be taking more medications for the same one. I talked about diabetes earlier on, about the fact that we're going to help treat diabetes, but also prevent complications. We also, with time, the diabetes will progress. Unfortunately, I mean, as much as we can, we'll try to control it, but in a lot of cases, it will progress. And so a same individual who's diagnosed at 65 for diabetes likely will be prescribed, I mean, first and foremost, exercise therapy, I hope, and nutrition therapy for them to work on lifestyle. But also, usually they're going to be prescribed an oral medication called metformin. That same person, you know, whatever, 15 years later, still has diabetes, but this time around, when we look at the medication list, they're on 3, so, or 4. So it's, that usually explains why we see this trend of increased medication exposure with age. It is also because, well, medications tend to accumulate, and they don't usually go the other way around. They're not reevaluated with this mindset of time has passed and what are the benefits, but more so that the condition progresses, so we have to be more aggressive. And it's often unilaterally applied that way. And well, that's going to be the lead on to my next slide. Benefits and risks of medications can change with time. And simply, a simplistic way here, just going to describe the major body changes that we observe in a body that explain why medications affect an older adult more than a younger adult. We'll just take an example of giving a same medication, same dose to a person, 25 years old versus 75 years old. So same sex, they will give it to a female in both cases. So there are changes in the body, and the arrows here kind of give a few clues here. The first thing that we want to flag in terms of older adults is that I don't know if you'll agree, but most people do. The brain is probably the most precious organ we have. And it is, for that reason, very well protected from viruses or any types of pathogens or any types of products entering the brain and to affect us, although it's not 100% impermeable. There is a barrier there called the blood-brain barrier. And with age, this barrier becomes less effective. So more of the medication can actually penetrate that tissue and have an impact on our brain. So that's where we get the concept of side effect. So when we're taking a medication that is actually targeting a receptor in whatever, say the bladder, because it's common for older adults to take medications for hyperactive bladder, for example, then that medication is supposed to go and act on the bladder. But unfortunately, in some instances, it will actually also have an impact on the brain and affect receptors in the brain. And so if that barrier isn't is letting the medication in a bit more, then we may have side effects like confusion or dizziness. Second point, and that's also a sad fact we're all aware of, is that with time, unfortunately, in terms of the fat and the water ratio in our body, or I could call it fat muscle being the water majority, and then the fat being the other part, the ratio tends to go in favor of fat over time. So we're going to increase our fat tissue versus our lean tissue. And the issue is that with that, and I'm sure David could tell us a lot about that, is that a lot of medication like fatty tissue, they like to accumulate in that the fat, and they will linger there. The problem with that is that it means the medication stays in your body much longer than what was actually supposed to or planned by the prescriber often. An example would be a sleeping pill. So medications that influence the nervous system are often, they like fatty tissue. So they'll accumulate in fatty tissue of older adults who have more and linger around for much longer than expected. So that's another issue that we need to flag and needs to be considered and certainly assessed when we're testing out medications. The last point I want to make about the way the body ages and the way it influences medication is, you'll notice this arrow here pointing towards the liver. We don't see the kidneys, they're hidden behind, but both of these organs play a key role in actually eliminating medications in the body. And with time, they become less effective at doing just that. I'd say that really, clinically speaking, what is relevant with is more so looking at kidneys for most of us. So kidney function will plateau at about age 40, 39, 40, and then it'll just go down slowly, gradually over time. And there's nothing we can do about that. However, if individuals have conditions that affect the liver, the kidney, this can increase drastically the degradation of kidney function, like diabetes can be a condition, or any type of really condition affecting the kidney. Otherwise, the liver, it's usually not that hugely important for medication elimination in terms of it really has to be really affected for it to clinically have an impact for what we know as of now. However, individuals who have had hepatitis C or who have suffered who have alcohol or alcoholics, for example, can have a liver that's quite damaged, and that can have an impact. But I usually mention, in terms of what we are taught as professionals, we are very focused on the kidney function, and we need to consider that in all cases. So that rounds up, I guess the slide is quite long to talk about, but it's essential to really understand why we are here with a situation that we don't necessarily like that much, because we're exposing individuals, as you see here, that physiologically are more vulnerable to medications, but we're giving them more than ever. So this slide just kind of summarizes a bit of what we've said before and puts emphasis on specific groups that are at higher risk. So I said that people age over 65 are at higher risk. Just refer to the past slide. That's exactly why, because of the changes in the body. People with chronic conditions and who have more than one, that's really referring to their capacity to adapt and say really function if they are suffering a side effect, for example. So people with multiple chronic conditions are usually not able to compensate as well and will end up suffering more from medication side effects. And then this group here, this often kind of sparks reactions. Women are at much higher risk of suffering side effects because of their physiology and biology, firstly. They are smaller, their kidneys are smaller, so we need to adjust the dose. They are also, the proportion of fat is higher in a female body as well. So looking at everything I just mentioned, a lot of the characteristics that we were concerned about, we see in women as well. We also see it as a way more side effects are being reported by women, more so in the gender societal way. We see that women tend to see their doctor more often, and if so, they also will be talking more about mental health issues. So they will be prescribed more medication in that category, which can significantly affect the risk of side effects and be at risk of causing them those harmful effects. So, and then they're also more prone to actually reporting side effects than men. So gender and biology both explain why we see more harmful effects of medications in women. So it depends where you look in the literature, but it's somewhere between 10–20% of hospitalizations in older adults that are actually caused by medication. So really nowadays, there's a reason to be concerned about the medications, because I mean, those are all interventions that were put together and done with the best intentions, hopefully by both doctors, the pharmacists, I mean, who dispensed the medication, explained it, the nurse who might have administered it. So for a number of reasons here, we're concerned because it has an impact on our health system today, and it's caused by the system. So that's what we really need to kind of be conscious of. So I briefly did talk about the fact that women are more at risk. And I forgot to mention the fact that, yes, they live longer, so they're more exposed to medication with time as well. I can perhaps pause here and ask if there are questions before we move on. I guess that's the first portion of the talk, is really to put a bit of context here, really end with saying really the proportion of hospitalizations are in older adults that are caused by medications is significant, and to really summarize the biology behind it and the reasons and what we're seeing in terms of medication use trends. Does anyone want to react, or should I move on?
I have a quick question.
Sure, I am.
When you talked about the kidney functions plateauing at 40 and then decreasing, and we can do nothing about that, is there a difference between males and females in terms of kidney functions?
Yes, exactly. So the fact that the female kidney are smaller than a male kidney. So at any age, we need to consider if the person is a female or a male, and we should adjust the medication dose in that context. Now, hear me well, if you're a healthy female, usually your kidney function is not, if it's reduced, it won't be clinically significant enough for a medication dose to be changed. But see. Particularly in older females, we need to be really conscious of that phenomenon. And I guess I didn't make the point that until now about the fact that in clinical trials, historically speaking, males were predominantly represented in any trial for medication, and often younger males. So the issue is that in the end, are we really using the medication that in the population that we tested it in? often not. It's changing. They're now actually making rules for it to be older individuals that are frail, because that's often the case. The population wasn't as frail as the group that we're actually administering the medication to in real life, and also higher proportion of females, which the pharmaceutical industry was so afraid of because of the risk of pregnancy. So that's why that's the reason they used for years to not include them.
Thank you.
So thanks for your question, Anne. So I'll move on in terms of, this was the context, that's where we're at. And now let's just go, we're just going to expose really and put light on the phenomenon that we call polypharmacy, or what we'll call when the risks of medications outweigh benefits or potential benefits. I guess, what we really need to reiterate in terms of medication is that in any individual, in any context, there is always a potential for harm. So a side effect of some sort, or the medication really being, the dose being too high, or et cetera, and having an excessive effect, and there's a potential for benefit. So in every context, we need to assess this benefit and risk and determine, should we go ahead with the treatment? Should we continue it? But we know that this isn't done as much as it should. And so that's why we end up with individuals who have internal infinite lists of meds, and it takes them, they need to end up in the hospital, unfortunately, or in long-term care before it's actually looked at, or if it ever is. So that's why we need to be really putting light on this issue. So as I mentioned, polypharmacy, if you've studied Greek, you probably just already see what that means. Multiple for poly, and medication, really pharmacy, pharmacopoeia. What we're looking at really is the definition of polypharmacy. It used to be really centered on just numbers, but now as I introduce the concept, you'll notice it doesn't really include numbers anymore. So it's really about looking at it from a global perspective and determining what are the risks of, and the risks can represent falls and fractures, issues with memory, ending up in the hospital, or interactions between medications. So we see that number is and information. It's not all of the information, but it can indicate a number of things. Firstly, we see that as we increase the number of medications in a single individual, their risk of falling increases. Now, with COVID, I think one thing that has been clearer than ever is that older adults want to live at home as long as possible, and avoid long-term care facilities. And that's the aim in terms of aging in place and offering them the services they need. The link I'm just making here is that falls are a huge burden in terms of bringing individuals into the long-term care facility kind of channel, because they'll fall at home and end up with a fracture, and then be in hospital for a while and not be able to reintegrate their home after, because of the fact that they need rehab. And it doesn't take long for someone to lose their ability to walk. And that in itself, if you have just 4 steps to get into your house, how are you going to function later? So that's where we're just trying to raise the flag and say, look, if you are on meds that increase your risk of falls, you have to take a look at that, because it may not seem very dangerous today, but in the end, it can have higher consequences, or consequences that you weren't necessarily aware of. And so 4 to 7 medication doubles the risks, and then 8 or more increases it even more. The point here is about, as we increase the number of meds, you're at higher risk of taking a medication that increase your risk of falling. I think it was Charles who mentioned, are we going to talk about diabetes meds and high blood pressure meds? Although I'm not going to specifically flag medications, I can say at this point here that taking high blood pressure meds that are too aggressively dosed, or too many of them, can increase your risk of falling. Because if you get up and your body is on a high blood pressure lowering dose, and you're just not able to compensate, it's possible for an individual to faint. And that happens a lot. Same with diabetes. If the dose of insulin is too high, Insulin is really a tricky thing to manage for any person. So just imagine someone who has a huge regimen of medication to take, or medications that lower blood glucose, blood sugar, can put you at risk of hypoglycemia, so low blood glucose levels, and fainting and falling and having a fracture. So those are just two examples. But any medication that has an impact on the nervous system in general, like antidepressants, medications for sleep, medications for nerve pain, like gabapentin or pregabalin or Lyrica. These medications are used for other things as well, but just to mention a few of the common ones, a same person could be on 5. So they all accumulate and will have an impact on this person and increase their risk of falling. The risk of interaction in itself, my point here isn't about telling people that you should know about interactions or the medications you're on and how they influence each other. That's not, I mean, people go to school to learn that for a reason because it's complex. The thing that I think needs to be flagged really is about making sure that once a medication is added or removed, it can influence the way others work. And so being say concerned or just flagging that and asking questions is always good to make sure that the medications continue to work in a consistent way over time. I guess, yeah, sometimes people are concerned about side effects, but we can see in some cases canceling out an effect as well. So it makes sense as we increase the risk of meds, as we increase the number of meds, we increase the risk of interaction. Just here, I know that most people are aware, but it's good to make the point that it's not because it's sold without a prescription that it is harmless. So a lot of over-the-counter medications are actually inappropriate for older adults. We think about medications that are used, for example, like Gravel, people take that for sleeping. I mean, if someone takes it for nausea and has a specific reason for it, and like it's all case per case, but we need to flag that anti-inflammatories often as well are bought over the counter and are not appropriate for everyone. So ask about those and make sure people that take care of you, health professionals, are aware of these medications because they are not harmless. Natural products as well, and vitamin supplements can interact with what you're on. So the picture is that I'm painting is really just to draw an idea of why we're concerned about those medications and how they impact the general public or anyone who's taking them, but specifically older adults as well. And as we increase the burden on a person, polypharmacy also means that that person is at higher risk of forgetting medication and or duplicating or making mistakes in general. So I guess as a pharmacist, it really was eye-opening to just make home visits. And we're at the pharmacy and we forget what things are once the person just leaves the pharmacy, and how it actually all unfolds when they're home. Whatever, the insulin is pretty much on the oven counter, and the medication is all piled up, and you just don't get how that person manages their medication. And often they just don't manage it that well. So what is the right, say, what proportion of doses are actually taken in the same person, in a person? Are we concerned about the way it's, when we're doing blood work to check on things, what really are we checking on? Are we sure that it's been taken the right way? So that's just a point to make here. And it's a lot that we forget. And I see David mentioning that in terms of medications that can lower blood pressure, you could point here the diuretics that are often used in order to treat high blood pressure. It can lower increase your risk of falls as well, just because the volume, we're increasing the elimination of liquid. So it's also a medication to consider. So when we look at an individual, we can look at their whole medication profile, but there's also a way to look at meds individually and see if they're appropriate. And there's an organization called the American Geriatric Society, and they publish a list of medications called the beers list, and not for beer. It's a kind of a ironic name, but it's for Mark Beers, who was the geriatrician who created that list. And it's a list really that is published for health professionals, for them to be aware of medications that should be avoided, and if so, in what context, and interactions, etc., and in what situations. So they publish it every 4 years or so. And that's one of the main resources that health professionals use here in Canada. And the definition of a risky or a potentially inappropriate medication, the way it's defined in that criteria, is really about what are the risks and the benefit in this population, because obviously when we're looking at the criteria, but then we can look at an individual as well. And secondly, is there an alternative? Is there a way for us to treat that condition which is as effective or more effective? So those are the two criteria that we're looking at in terms of what a risky medication is. And then, right, we're thinking, what is a risky med? Well, an example would be sleeping pills in older adults. They are considered risky. Firstly, when we look at the main definition, or the first part of it, would be risks outweigh benefits. When we look at the benefits of having a sleeping pill on board, it's minimal. And the actual truth is that sleeping pills in trials have been tested usually for an average of 2 weeks or more, not more than 4. And if you look at a monograph, which is the recommendations that the pharmaceutical company, or everything that you should know about the medication, that's written in very, very small lettering next to the medication, they'll mention that the sleeping pills are not intended for long-term use. Unfortunately, as a pharmacist, I've very rarely seen people take them for 2 weeks and then stop. In fact, they're taken for years on really average. So the benefit when they looked at older adults taking sleeping pills is minimal, is marginal. So 14 minutes faster to fall asleep. But on the other end, when we look at big data, meaning when we look at the harms in the population, so epidemiological data, we see that there's an increase in falls and fracture, motor vehicle accident, and issues with memory. So the reason why we see that is that sleeping pills have an impact on many different brain functions, either memory, planning. So if we're going to drive a car, it's not surprising, right, that our reaction time isn't as good as it should be. And our coordination between our movements, meaning we may not see the electrical cable that we're usually going to step over. With that sleeping pill, we're just not as awake when we get up at night to go to the bathroom. So this can explain why we end up with those unfortunate events. The other component of a risky medication is that there's an alternative for it. The alternative for sleeping pills is CBTI, or cognitive behavioral therapy for insomnia. CBTI is generally can be put in place by individuals on their own. In fact, if they've shown that individuals are able to do it, but it takes a few weeks to put in place. What it is about, it's about retraining your body to associate the bed with sleep. So it'll train, it'll look at things like getting up every day at the same time and not staying in bed. So if we have to get up at 7, we get up at 7. Not taking naps, looking at caffeine intake, working on meditation, relaxation strategies. So a bunch of different approaches. At the end of my talk, I'll show you a handout that we developed at the Research Center on CBTI, and you'll be able to access it. So that may be of help for individuals that are either have insomnia and want to put in place these strategies, or are taking sleeping pills and are thinking about, maybe I should start this discussion with my pharmacist, my doctor, but what can I do instead? And then you'll have those information on hand. David mentioning interactions between prescription meds and cannabis. So there are a number of ways cannabis can influence or can have an impact on prescription meds. Often, so it's about accumulation of effects, or the same way that your pharmacist may tell you, you shouldn't drink alcohol with this medication. the way that the alcohol in itself is not going to impact the way the medication is eliminated or the way it acts on you, but you're going to accumulate. So they both have effects on your nervous system. So say cannabis will be just kind of lowering your response rate, kind of having an impact like we can see here. So reaction time is slower. We're just kind of depressing effect on the nervous system is how we would call it, just to make it less aware. And then we're adding, other medications on top, like sleeping pills or medications that make you drowsy or dizzy. So you can have interactions there to have more than a double up effect. You can have a symbiosis there, and it'll have an impact that is much stronger than expected. So I'd say that anything that has an impact on the central nervous system, you have to be really cautious with, especially with cannabis. So those medications that are identified in the Beers list, unfortunately, are not rare. So the point of this list is to actually identify meds that shouldn't be used in older adults. But the issue is that we're seeing that they're being used, and quite a lot. So in Canada, about 1 in 3 men take one of them, and 42% of women take one of them. So it's concerning to see that. And although recommendations are made, they are just very common. And the other point I want to make is that as you age, even above 85, you're at higher risk of being exposed to a risky med or an potentially inappropriate med. So about half of women are taking one medication that's considered risky. All to say that really there's work to be done, certainly, and that it costs us a lot as a society. Our aim as an organization isn't to save money, but really obviously to flag that we're spending money on the medications that are inappropriate. We're spending money on the consequences that they cause. How about thinking if we could, make alternatives that work, like psychotherapy, physiotherapy, CBTI we talked about. How about making those more accessible to individuals to give them an option? Because the issue right now is if you have back pain and you don't have coverage for physiotherapy, but have coverage for medication, which could be the case for a lot of older adults, you're likely to turn towards pills and not towards a session with a physio that's going to assess you and give you exercise therapy or something that's much less riskier and works, which isn't the case with medication, often cases especially with back pain. So that's the second part of the talk. It's about really describing the consequences, describing what a risky medication is, and also the polypharmacy phenomenon that we're observing. The last part of the talk is really about what we can do about it. Hope we can actually give practical ways to approach this. So our organization, which I should just talk about briefly, is we're a group of patient advocates, health professionals, researchers, and policymakers from all around Canada. And we all consider that the pendulum has swung too far. So we are using medications automatically for a number of conditions for whom other approaches could be selected. One example to kind of describe this in another way would be proton pump inhibitors. So medications that are used for stomach acidity, and they're taken by 1 in 3 seniors in Canada today. So proton pump inhibitors are often used for acid reflux. But we also know that acid reflux is caused by most often our lifestyle. Are we eating fatty meals, very spicy meals? Are we exercising enough? Because being overweight is a risk. Are we smoking? Smoking is a risk factor for acid reflux as well. And there's a number of ways an individual can treat their acid reflux without meds. But unfortunately, it is often the easiest way out to be taking a pill, and they have side effects as well. So overall, they're generally safe, but they're used by so many people that they end up causing side effects in some when they're taken by 1 in 3 people. So our organization thinks we should just kind of bring things back to, taking meds, but not automatically for everything, as it is the case often. So we put our proposal, or what we put forward, is that we need to consider deprescribing. When a person takes too many medications or not the right one, they should be putting in place deprescribing. And it's really the opposite of prescribing. So it means either reducing a dose or stopping a medication when it isn't beneficial, or if it could cause harm. Really, that's the short and sweet definition of deprescribing. We're really working on quality of life here, more so than longevity, or although it depends on each person here, but really what we want to do is to make sure the patient and the provider are both very comfortable with the treatment the person is on, and that it's monitored over time. And yes, it's done as a team with the clinical providers that are involved. So never by a patient on their own, because stopping abruptly a medication that shouldn't be stopped that way can cause a bunch of other problems, which we're not much better off in that context either. So really what it's about in terms of what you can do or what you could do for the others that you take care of is about really planning an appointment to discuss your medication with your doctor, your pharmacist, or your nurse. So I know I'm offering this presentation to people that live in Ottawa, so I'll contextualize it to the Ontarian, healthcare system and what I'm aware of in terms of resources in that region. So in Ottawa, in Ontario, pharmacists are, they can be reimbursed and supported for the provision of what we call a meds check. So that's a way for them to actually assess the medication and make recommendations to the doctor. So I think if you're on 3 or more meds, it's covered by OHIP card. And yeah, they can look at medications. So that's a way for you to ask about these your medications and get them reassessed by the pharmacist and assess if each and every one of them are still needed. The other way would be to obviously speak to your doctor about it and book an appointment and discuss your medication, or discuss the ones of a patient or person you're taking care of. The last approach I'd like to suggest is that in most of the family health teams in Ontario now, there is a pharmacist there. Pharmacist that's not a retail pharmacist. They're there to help the team, and they are there to support and provide the best care in terms of medications. So you could access this service by asking about it if you're concerned about a medication, want to know how to stop one of them. Each clinic usually has a pharmacist there in the family health team system. So 3 different approaches. Community pharmacy is usually the easiest to access, retail pharmacy, sorry, but then if you have a good access to your family health team, then also an excellent way to look at it. In terms of asking questions about the meds, we have identified 5 broad questions to help you determine where to go next and where you're at with this process. And it's an iterative process in a way that we're assessing the medication. People ask me how often. Well, usually if an individual is on a medication, they should be reassessed yearly, even more so if they're on 5 or more, for sure. And reassessing a medication doesn't mean it needs to be stopped, but it could also be, the dose could be lowered, for example. And that's deprescribing as well. Pharmacy, really the philosophy, and I guess in medicine in general, is the lowest dose that's effective at any case. So that's really what we're about. So why am I taking this medication? Maybe reflect on this prior to the appointment and looking at all of the meds you're on, or the person you're taking care of is on, and identifying why they're there. What is it for? If you're unable to answer some of the questions, that's a start off point for discussion. Then discussing the benefits and the harms of this medication, asking about them to determine what are you expecting from this treatment in terms of side effects? Are they possibly affecting you without you noticing, or you didn't link both of them, the side effect and the medication? Can it affect my memory or cause me to fall? I guess here we just like to flag, because those are very common side effects, and they are of high concern for older adults. They come really high up in terms of concerns. So asking specifically about them can really open up doors and spark conversation. Fourth question would be really, it's straight to the point, but then as you've asked the question, then you can necessarily learn. And if the answer is no, well, what did you lose? Nothing. You actually have an answer. Can I stop it? Can I reduce the dose of this medication? So asking about it is always the best way to kind of see if there's a possible avenue there. And who do I follow up with and when? So if nothing's done, I mean, if you're on the medication, then the physician or the pharmacist, saying, well, you're on 3, but looking at your health profile, the 3 of them seem appropriate. Then who do I follow up with in the terms would be, what it means here would be, when should we do this again? Really, because this is, as I mentioned, an iterative process. Otherwise, who do I follow up with if you're actually going to deprescribe, reduce the dose, stop a medication? Well, when are you going to be checked up on? Who is going to follow up with you? Because usually we have to kind of make sure that you're aware of things to look out for and to see how things are going, to make sure that everything's fine over time once we stop the medication. When we look at what the science shows us in terms of deprescribing, it is generally very safe. In some cases, the condition can, if we're talking about high blood pressure, the medication is stopped and then they'll follow up. Most people will be okay if they're tracked, but in some instances, the blood pressure will increase a little bit and then the medication started again if needed. But that's a minority of cases, and that's why we are very, we're reassured to see that in general, it's done very safely and for the benefit of patients. So it's about informing yourself, and you're here today, so I don't even need to reiterate how important it is. It seems to be already, but also, I guess, engaging with others. So what we encourage you to do is to start that discussion, spread the word about deprescribing. It's a new word, new-ish. It's not even 20 years old, but we're seeing it more and more. And health professionals are starting to familiarize themselves with it as well. So when patients ask about it, they can actually feel that it's something that's important and it's on the ground as well. So talking about it to policymakers as well. I mean, for them to realize that funding medications is not just the answer for everything. So we need to make sure that patients have access to all of the best therapies that are available to treat, say, their sleep condition or their acid reflux, for examples that I've given until now. I'd just like to end my talk with an example of it. It's a different country, it's a different context, but still quite strikingly, I guess, just to kind of show that we're not just, marginals or people that are raising a point that isn't relevant. In fact, other countries have just taken this and really faced the issue in a serious way. So in Denmark, they really assessed and saw that a lot of older adults were taking sleeping pills and strong sleeping pills. And they saw that it had an impact on the risk of accidents in terms of motor vehicle accidents. So they put in place a policy to limit the access to driver's license for individuals who took sleeping pills. They asked people that were over age 70 to decide, and that was done with the collaboration of health professionals. If you're taking the sleeping pill, we will take your driver's license away. So that's a very radical way. If you look at it from a Canadian perspective, it does look radical, but it's definitely for them, what was most important was really reducing the accidents in the same way that we don't let people drink and drive with a sleeping pill, that they weren't as aware of what they were doing on the roads. So unsurprisingly, the policy was very effective at reducing sleeping pill use. with a 66% reduction of use in that population. But it took time, okay? But still, I'd just like to end it this way, just to kind of say that raising awareness is a way to change things, but we all know that the policies are often, that are stronger, will often change things in a more dramatic way or reduction. So there's a whole spectrum of way we can help improve the way we use medication. So I'll send my slides after the presentation to David for him to share it with you all, but I invite you to check out our website. This is where you'll find all of the tools to help you engage with the health professional, brochures on specific meds like sleeping pills, like pain medications, like some of the diabetes medications, to help you decide with your health professional if they're still the right ones for you, and if not, how to stop them. A brochure I mentioned about sleep. So there's a number of things, really, articles. If PAL has a newsletter, if you're sharing stuff through other community groups that reach anyone, we're here to spread the word, really, in terms of helping you disseminate that information, so we're able to adapt our message as well. So this was obviously before the pandemic, but we're raising awareness and continuing our efforts. Hopefully we're going to be able to get back to this type of model later, soon enough. But in the meantime, yes, we're all virtual, and hope you enjoyed the talk today, and I appreciate you being here. So thanks again.
Merci beaucoup, Camille. This was so informative. One of the things I'm really impressed with is the fact that, I mean, you're in this business, but really stressing the importance of pharmacy in our healthcare system. And unfortunately, it's traditionally taken sort of a back seat. You know, you get a prescription from your GP or a specialist, you go to fill it at the pharmacist, and you see them as somebody in a white lab coat behind a counter, and that's it. But I've always believed that, and I think the audience would agree with me, that the profession of pharmacy has to be elevated to be on the same level as other healthcare practitioners, because there's such an integral part to people's functioning. I have a question for you. Are you seeing any, I don't know whether or not there are any measurements on this, but are you seeing any progress in physician prescribing or adequately, or nursing homes or hospital staff, or is there resistance to the pharmacy profession in collaborating with them?
That's a great question. So we are tracking medication use in older adults very closely to see how things evolve over time. And we have about 10 years to look back, say, with the same data. And it's hard to say, I can't say, yes, there is an overall improvement, but when we look at specific categories of medications, we do see some improvements and some degradation. So one thing we're seeing that is, say, improving would be use of sleeping pills. So that one has been, I think there's been a lot of, awareness is there, and they were quite popular. Benzodiazepines like Xanax and all of that family, they were very popular in the 70s, given out to a lot of individuals and very easily. So I think that it's also a generational thing in terms of prescribing, in terms of the physicians being taught in school and what they are used to. So that, in terms of use of sleeping pills, we've seen this. It's not near where we want it to be, but it's going down in most of the provinces, although still high in the Atlantic specifically. Otherwise, when we look at opioid medications, it's been reduced as well because of all of the campaigns around the opioid crisis that we've had. So it's a number of things that create a context that reach or not professionals. So they've been really aware of the risks that opioids entail, and that we've seen go down. Otherwise, proton pump inhibitors on the other end are keep just going up and up and up. and they are being used by more and more people. So then we see provincial jurisdictions trying to reduce their use through policies, trying to say limit their reimbursement through the plans, etc. So there's different ways. There are different ways to act, but so it all depends. I'd say that in terms of overall medication use, it's still increasing all the time. So, and the way that is that often clinical guidelines for different conditions usually tend to add in, more meds with time. So if you have asthma today, then if you look at the way that should be taken charge of by your doctor, there's more meds today than there were 6 years ago. So unfortunately, they don't think about the deprescribing as much as they should in their guidelines to help prescribers identify when the medications are not needed anymore. Yeah. So long answer to say that, yeah, it's going up in some cases, down in others, but I'd say awareness is there on the ground, but the means to do it need to be reinforced. And the fact that physicians are renewing medications often at the end of an appointment quickly, you go in for another reason, and at the end you say, oh, I need repeats for, and then they'll just check on the computer and print the prescription and give it. Then there wasn't really an assessment there of the therapy.
Interesting. Yeah. And you have a question?
Yeah, a question, I guess a few comments. And the first thing that comes to mind with the pandemic and levels of anxiety and depression and isolation. And I imagine there's probably been an uptake in prescriptions for those sorts of symptoms. And I would also wonder about the number of young people who are suffering from anxiety and depression, and that maybe, these statistics are going to be turned on their head when we look in a few years to see how many younger people have started taking medications at such an early age compared to, as you're talking about, the older we get, the more medications we take. That trend may be challenged by what's happened during the pandemic and how younger people are dealing with it. And I wonder, what's going to happen when they have to try and deprescribe, if you will, or try to come off some of those medications. Like, in other words, are we heading towards another kind of a crisis? I don't know.
The preliminary numbers that we're seeing is that, yes, Anne, you're totally right. There's an increase in the use of any psychotropic medications, and more so in younger females. This is first. Well, what we kind of observe is that, as we know, the pandemic is not equal in terms of the way it's hitting, but young mothers who needed to cope with, if they work from home with kids, etc. So all of the ways that it's affected that group there are multiple ways, but yeah, psychotropic medications are up, and the way that they're going to be, in terms of how to make sure that people don't stay on them for years, is certainly needs to be addressed in the future.
Yeah.
Good point.
That's great. Does anybody else have any questions for Camille? Anything they'd like to know? Nothing in the chat line. Well, this has been really, really helpful, Camille. We at PAL Ottawa are going to be developing a housing called affordable housing for artists, for arts workers in Ottawa, and we'll be having almost 100 people, if not more, working in this building. So they'll be aging in place, and medication mismanagement amongst as well as so many other health issues will have to be monitored and certain interventions taken. And the more education that constituency has, whether it's membership or people living in Palplates, the more empowering it will be for them, and the greater the opportunity they'll have to age in place. So medication mismanagement is so important. I know from my own personal experience, my late mother, I remember her hospital here in Ottawa being there for a, she fractured her hip, but she developed a urinary tract infection. So I came in one day and I noticed that she was like, delirious. So I immediately checked her chart, and I found out that staff, without the approval of my brother and I, had put her on Dilaudid, I believe, Dilaudid. And, I ordered a family conference right away, and I said, why is my mother on this drug? And they said, well, to treat the UTI. I said, well, to my knowledge, you don't use Dilaudid to treat a UTI. Completely different. So they immediately took her off that medication, and within about 2 days, she was back to normal. So, all this education about the beers list that you mentioned, which is so important, and all this education about pharmacy, about illnesses and diseases, the body itself is so important as we age, rather than us relinquishing all our power and decision-making just to professionals. I mean, obviously, they have the greatest education and understanding, but the balance, there has to be a greater balance between who has all the information and who doesn't. And the information that you provided today will be so invaluable for us going forward. So we thank you for that very much.
Well, thank you for the invitation. And if anyone wants to reach out, that it's going to be in the slide. We have the email there, so don't hesitate to reach out to us. In terms of disseminating the information with other people, we can definitely help organize more of this type of event, or just written information as well.
That's great. Thank you so much. David, are you still there? Are you frozen? I think David's frozen.
Yeah, it seems so.
Oh, we started with problems, we end with problems.
At least the middle was okay.
It was an excellent presentation, and I'm sure we'll get lots of hits once it's posted to YouTube.
Awesome. Well, thank you, Anne, once again.
Thank you. Thank you
Have
so
a very
much.
good afternoon. Bye-bye.
And you too. Bye-bye for now.